Good morning to one and all. Myself, Dr. Kalaivani, Senior Resident in the Department of Obstetrics and Gynecology in Sri Lakshmi Narayana Institute of Medical Sciences, Puducherry. I'm here to talk about vaccination during adolescence period. So, immunization is not just for infants and children under 5 anymore. So, vaccination is important and must for adolescents and for adults too. Why we have to target adolescents? The immune protection provided by the childhood vaccinations may not cover adolescent period. This may happen because the effect of vaccination wanes off during adolescence period. So it may be the initial vaccination in childhood was not given or was given in inadequate doses. So if there is underlying chronic diseases in adolescents or certain high-risk groups also demand vaccination for their protection. So, for adolescent immunization, it is a collective responsibility for the gynecologists, pediatricians, teachers, and parents to ensure that they are cared for the adequate vaccination. Now, coming to the recommended adolescent vaccines, as per IAP recommendation, this immunization schedule for children aged 0 to 18 years in 2016 are recommended vaccines are BCG, hepatitis B, polio, DTP, Tdap, Haemophilus influenza B vaccine, pneumococcal vaccine, and PPSV 23, rotavirus vaccine, MMR vaccine, that is measles, mumps, and rubella vaccine, varicella vaccine, hepatitis A, typhoid, influenza, human papillomavirus vaccine, meningococcal vaccine, cholera, Japanese encephalitis, and rabies. Since 2016, the recommended adolescent immunizations in India for the age group of 11 to 12 years, Tdap vaccine, HPV, annual influenza vaccine is recommended. For the catch-up immunization, the recommended immunizations for adolescents are MMR vaccine, that is measles, mumps, and rubella vaccine, hepatitis B, typhoid, varicella, and hepatitis A vaccine. For the high-risk groups, the recommended adolescent immunizations are pneumococcal vaccine, meningococcal vaccine, Japanese encephalitis, cholera, rabies, and yellow fever. Now, the vaccines recommended for all adolescents at the age group of 11 to 12 years. Now, coming to the Tdap vaccine, that is, diphtheria is purely a vaccine-preventable disease. It used to be a disease of children aged 5 to 7 years, but now there is a shift to the right in epidemiology. There is a huge resurgence of the diphtheria in last few years. Cases in India far outnumber those of any other country in the world, according to WHO. As per DGHS survey, the incidence of diphtheria cases in 2010 reported was 3,343, whereas in 2011 it was reported as 4,233. It was an increasing trend in a few years. India contributes 86.66% of the diphtheria cases reported globally. Why do adolescents need pertussis vaccine? Pertussis is an endemic disease. So outbreaks of the pertussis are still occurring. The general trend has been an upward rise. The adolescents are responsible for the spread of the pertussis in the community. So immunity to the pertussis lasts 3 to 10 years. Now, India contributes more than 43% of pertussis cases reported globally. International Consensus Group on Pertussis and Global Pertussis Initiative recommendation for vaccine, that is, there is a need to vaccinate all adolescents for the age group between 11 to 12 years against pertussis. Vaccination ensures an increase in herd immunity. The Tdap vaccine, we have to administer one dose to all adolescents aged 11 to 12 years or at any greater age if it has not been given earlier. The boosters after that are TD vaccine, which is given every 10 years. It can be administered at the same time as other adolescent vaccines, so that the efficacy of Tdap vaccine was 92%. Now coming to the HPV vaccination. Every woman in India is at a risk of cervical cancer. 1 out of 4 women who die due to cervical cancer in the world is in India. The risk of cervical cancer is strongly related to the age at first intercourse. The relative risk for cervical intraepithelial neoplastic lesion, that is a pre-malignant lesion, and invasive cancer increases with decreasing age of first sexual intercourse. Based on the evidence, IAP recommended the use of HPV vaccine in its immunization schedule since 2007, but there is no coverage data on uptake of this HPV vaccine. So that common perception is that acceptance is poor and the coverage still remains minuscule. In India, both IAP and FOXC recommended the HPV vaccine for the minimum age of 9 years. For girls aged 9 to 11 years, only 2 doses of either of the 2 HPV vaccines can be given. For 2-dose schedule, the minimum interval between the doses should be 6 months. Catch-up vaccination is permitted up to the age of 45 years. For girls aged 15 years or elder and immunocompromised, 3 doses of HPV vaccines are recommended. For 3-dose schedule, administer the second dose 1 to 2 months after the first dose and the third dose 6 months after the first dose. Use the same brand of HPV vaccine for the entire fetus. As per the WHO Strategic Advisory Group of Experts recommendation, the revision of HPV vaccination scheduled for the pre-adolescent girls from 3 primary doses to 2 doses since 2014. The move to revise the HPV vaccine immunization schedule from 3 doses to 2 doses would not only be cost saving but would also help in improving the acceptance and enhancing the coverage of the vaccine. Now coming to the efficacy of the quadrivalent HPV vaccine. For HPV, that is a human papilloma virus induced lesion, the protective efficacy of the quadrivalent HPV vaccine is 98% for cervical cancerous and precancerous lesions with grade 2 or 3. It is 100% protective for vulval and vaginal precancerous lesions with grade 1 to 3. It is 99% protective for genital warts. Now coming to the influenza vaccine. Flu can be serious even for healthy adolescents. There are 2 types of influenza viruses. One is type 1, type A, and type B. Adolescents with high-risk conditions, they are more likely to suffer flu complications. Flu seasons are unpredictable and it can be severe. Type A influenza virus can be divided into several subtypes based on the 2 surface antigens, that is E. agglutinin and neuraminidase, for example H1 and N1, whereas influenza type B is not categorized into subtypes. Now coming to the influenza vaccine, there are 2 types of flu vaccine available in the market. One in the injectable form, that is a trivalent inactivated killed influenza vaccine, and another one is intranasal live attenuated influenza vaccine. Both the vaccines are made from viruses which are grown in eggs. So this vaccine should be avoided in the patients, those who are allergic for chicken or egg protein. An egg-free vaccine is also available in the market nowadays. Both the vaccine, it includes 2 type A strains, that is H3N2 and H1N1, and 1 type B strain. As far as the recommendation considered, adolescents should receive a single dose of influenza vaccine every year. The best time to vaccinate against influenza is as soon as the vaccine is released and available in the market or just before the onset of rainy season. The recommended strains may change annually, so in view of changing strains, the antigens configuration for influenza need a new model vaccine every year, so that influenza needs very frequent updating. Catch-up immunization for adolescents. As per IAP recommendation, the catch-up immunization is recommended for those who fall behind or start late. We have to provide catch-up vaccination at the earliest opportunity. So, as per IAP recommendation, the following vaccines are recommended for adolescents for catch-up vaccination. It includes MMR vaccine, that is measles, mumps, and rubella vaccine. At least 2 doses at 4 to 8 weeks interval. If 1 dose should be given if previously vaccinated with 1 dose. For hepatitis B vaccine, 3 doses should be given at 0, 1, and 6 months interval. For hepatitis A, 2 doses can be given at 0 and 6 months interval. Before vaccination, we have to check anti-HAV IgG antibody, which may be cost effective. A combination of hepatitis B and hepatitis A may be used in 0, 1, and 6 schedule. Now coming to typhoid vaccine, 1 dose should be given every 3 years. At least a minimum interval of 3 years should be observed between the 2 doses of typhoid vaccine. And varicella vaccines, 2 doses should be given at 4 to 8 weeks interval. Now coming to MMR vaccine. All school-going children and adolescents should have at least 2 doses of MMR vaccine, that is measles, mumps, and rubella vaccine. 1 dose should be given if previously vaccinated with 1 dose. So minimum interval between the 2 doses of MMR vaccine is 4 weeks. So during outbreaks, if standalone vaccine is given to the infants, it should not be counted. Now coming to the chickenpox. As per 2007 CDC recommendation, most cases of chickenpox are mild, but adolescents and adults, they are at risk for severe disease. Prior to vaccinations, annually 4 million cases were reported and 10,600 cases were hospitalized. 100 to 150 deaths were reported. But after vaccination, there is a decreasing trend noted in chickenpox incidence, hospitalization, as well as death, whereas the cases were decreased to 88% and 88% decrease in hospitalization were reported, and there is 90% decrease in death due to chickenpox. Varicella vaccine. For catch-up vaccination, we have to ensure that all adolescents aged 7 to 18 years should have 2 doses of the vaccine. For children till 12 years, a recommended minimum interval between the doses is 3 months. For children 13 years and older, the minimum interval between the doses is 4 weeks. Now coming to the hepatitis A. As per the expert group for hepatitis A, the universal immunization is not recommended as yet because the seropositivity rate exceeds 50%. The prior check of the hepatitis A antibody titer IgG is cost effective and it is recommended. Hepatitis A vaccine, it has 2 types. One is a live attenuated H2 strain hepatitis A vaccine. Another one is killed inactivated hepatitis A vaccine. Either of the 2 vaccines can be used. We have to administer 2 doses of inactivated vaccines 6 months apart. Only single dose of live attenuated H2 strain vaccine is highly immunogenic and highly efficacious. Essentially, 100% are protective levels of antibody after the second dose. Now coming to hepatitis B. The prevalence rate of hepatitis B in India is 1 to 2%. And the overall rate of chronic HBsAg positive rate in India is 4.7%. Hence, we have to give catch-up vaccination for adolescent age group to prevent the chronic complications. Recommended vaccine for hepatitis B is recombinant hepatitis B virus vaccine. 90% successful rate was reported. 3 doses of hepatitis B vaccine to be given to those previously not vaccinated at 0, 1, and 6 months schedule. The combination of hepatitis B and hepatitis A may be used at 0, 1, and 6 months. Now coming to typhoid vaccination. The committee strongly urges the government of India to include universal typhoid vaccination in its universal immunization program all over the country at the earliest. For the catch-up vaccination, the typhoid vaccine is recommended throughout the adolescent period up to 18 years of age. There are 2 types of typhoid vaccine available in the market. One is the conjugate vaccine and another one is polysaccharide vaccine. Conjugate vaccine should be preferred over the polysaccharide vaccine wherever feasible because the need and exact timing of the booster doses are not yet determined. Typhoid revaccination every 3 years is recommended if polysaccharide vaccine is used. An interval of at least 4 weeks with the MMR vaccine should be maintained while administering the typhoid vaccine. For high-risk cases, IAP recommended certain immunization schedule for adolescent groups. Now, as per IAP, there are certain high-risk category has been proposed. One is children, those who are infected with congenital or acquired immunodeficiency, including HIV infection, and those who are infected with chronic cardiac disorder, pulmonary disorder, including asthma, if treated with prolonged high-dose oral corticosteroids, and renal disorders, including nephrotic syndrome, liver disease, and hematological disorders, and children, those who are on long-term steroids, on long-term salicylates, immunosuppressive therapy, or radiation therapy, those who are infected with diabetes mellitus, especially type 1, and cerebrospinal fluid leak, and those who are with cochlear implants, and malignancy infected children, and children with functional asthenia or anatomical asthenia, or those with hyposthenia, and for travelers and children who are having pets in home. In special circumstances, IAP recommended immunization for adolescents. The following vaccines are recommended most commonly in special circumstances. One is a meningococcal vaccine. 2 doses are recommended. Japanese encephalitis vaccine, that is a catch-up vaccination, is recommended up to 15 years of age, only in endemic areas. Pneumococcal vaccine PPSV23, 2 doses are recommended with 5 years apart. Maximum number of doses for pneumococcus is 2 vaccines. Rabies vaccine 0, 3, 7, 15, 28 days. That is a 5-day schedule is recommended as soon as possible after the exposure. Cholera and yellow fever, only in endemic area catch-up vaccination is recommended. Now coming to meningococcal meningitis. The annual incidence of meningococcal meningitis reported was 3,000. 10% of these cases will die because it has high case fatality rate. 20% of those who survive with meningococcal meningitis will suffer serious long-term disability such as hearing loss with organ failure and limb amputation. Often, meningococcal meningitis is misdiagnosed as something less serious like flu. It spreads rapidly, often within hours of first symptoms. Now, for the vaccination, 2 types of vaccines are available in the market for meningococcal meningitis. One is a polysaccharide vaccine. It includes bivalent vaccine for type A and C, and quadrivalent vaccine for type A, C, Y, and W135. And another type is a conjugate vaccine. It is available in the 2 formulations. One is a quadrivalent vaccine and another one is monovalent vaccine. Conjugate vaccines are preferred over the polysaccharide vaccines due to their potential for herd protection and their increased immunogenicity. Now coming to the meningococcal conjugate vaccine. 2 doses of MCV4 are recommended for adolescents aged 11 to 2 years. First dose should be given at age of 11 to 12 years and booster dose should be given at 16 years of age. Adolescents who receive their first dose at or after 16 years of age, they do not need a booster dose. Now coming to the pneumococcal vaccine. 2 types of vaccines are available in the market. One is a pneumococcal conjugate vaccine. It includes PCV10 and PCV13. And another one is a pneumococcal polysaccharide vaccine, that is PPSV23. The risk of serious pneumococcal disease is relatively low, but it is not recommended for routine use in healthy individuals. It should be recommended only in high-risk group of children. A single dose of PCV13, that is a conjugate vaccine, is given to previously unvaccinated children, those who have anatomical or functional asthenia, including sickle cell disease, HIV infection, those who are immunocompromised, or those who are with cochlear implant or CSF. We have to administer PPSV23 at least 8 weeks after the last dose of PCV. An additional dose of PPSV should be given after 5 years to children with anatomical or functional asthenia or if immunocompromised. PPSV should never be used alone. The maximum number of doses for pneumococcus is 2 as per recommendation. We have to give PCV13 first, followed by MCV4 4 weeks later, so that pneumococcal vaccine and meningococcal vaccine should not be given simultaneously. It can be co-administered with live vaccines such as the influenza vaccines. Now coming to the cholera vaccine, it is available in the market as inactivated wholesale Vibrio cholerae vaccine. It is not recommended for routine use in healthy individuals. It is recommended only for adolescents, those who are residing in the highly endemic areas or those who are traveling to areas where risk of transmission is very high, like Kumbh. Two doses of Quadrivalent are given 2 weeks apart. Now coming to the Japanese encephalitis vaccine, it is recommended only for individuals, those who are living in or planning to visit in endemic areas till 18 years of age. All susceptible children up to 15 years of age should be administered during disease outbreak ahead of anticipated outbreak in campaigns. There are two vaccines available for Japanese encephalitis. One is the live attenuated vaccine, which is a cell culture derived vaccine, is available in the market as SA14, 14-2, NA, and another one is inactivated cell culture vaccine, which has been derived from SA14, 14-2. Two doses to be given with 4 weeks apart. Most common route of administration is intramuscular. The need of booster doses still undetermined. And another one is inactivated vero cell culture derived polar strain, that is 821564XY. For this vaccine also, we have to give 2 doses intramuscularly at 4 weeks interval. Need of boosters still undetermined. Now coming to rabies. Rabies is one of the oldest and most feared diseases reported in the medical text. We can prevent rabies by giving both pre-exposure as well as post-exposure prophylaxis. Rabies vaccine. Practically, all children need the vaccination against the rabies. High-risk category for pre-exposure prophylaxis are children, those who are having pets at home, children with higher threat of being bitten by dogs such as hustlers, and risk of stray dog menace while going outdoor. Now coming to the WHO approved vaccines for rabies, it includes purified chick embryo cell vaccine, that is PCECV, that is Rabipur vaccine or Novartis, which is available in the form of 1 ml, and human diploid cell vaccine, that is Rabivac, which has been prepared from the Serum Institute, available in 1 ml formulation, and another one is purified vero cell vaccine, that is PVCV. In the market, it has been available as Vero Ram. It is in the formulations of 4.5 ml. Only modern tissue culture vaccine, that is MTCV, and intramuscular routes are recommended for both post-exposure as well as pre-exposure prophylaxis. Now coming to the pre-exposure prophylaxis for rabies, 3 doses are given intramuscularly in deltoid or in the anterolateral aspect of thigh on day 0, 7, and 28. Day 21, if there is limited time, but day 28 is preferred. First booster dose at 1 year and thereafter every 5 years we have to give for re-exposure at any point of time after completed and documented pre-exposure or post-exposure prophylaxis. Only 2 doses need to be given on day 0 and 3. Rabies immunoglobulin is not required during the re-exposure therapy. Now coming to the post-exposure prophylaxis for rabies. It should be started as soon as possible after exposure based on 5-day schedule, that is day 0, 3, 7, 14, and 30, with day 0 being the day of commencement of vaccination. A 6th dose should be given on day 90. It is optional and it may be offered to patients with severe debility or those who are immunosuppressed. Our another topic is vaccination. During pregnancy, adult immunization rates have fallen short of national goals, partly because of the misconceptions about the safety and the correct vaccines. The danger of these misconceptions is magnified during pregnancy when concerned physicians are hesitant to administer the vaccines to the pregnant mother, as well as the patients are reluctant to accept them during pregnancy. The administration of vaccines during pregnancy poses a number of concerns about the risk of transmitting a virus to a developing fetus. The risk of transmitting a virus to a developing fetus is primarily theoretical. whereas the theoretical risk of vaccination must be outweighed against the risk of the disease to the mother as well as the fetus. Immunization during breastfeeding is safe, so that physicians should reassure their patients that no vaccines are contraindicated during breastfeeding. The routine vaccines that are generally safe during pregnancy includes six vaccines. One is diphtheria, another one is tetanus, influenza, hepatitis B, meningococcal vaccine, and another one is the rabies. The vaccines that are contraindicated during pregnancy, it includes live virus vaccines such as measles, mumps, and rubella, that is the MMR vaccine, and another one is the varicella vaccine, a BCG vaccine, yellow vaccine, and polio because of the theoretical risk of fetal transmission. The live virus vaccine is inadvertently given to a pregnant woman, or if a woman becomes pregnant within 4 weeks after vaccination, she should be counseled about the potential effects on the fetus. Now coming to the MMR vaccine, that is measles, mumps, and rubella. Measles is nothing but is a rubeola virus, which is a member of the rubivirus family. It is typically present with fever and red eyes as well as coryza, that is the inflammation of mucosal membrane lining the nasal cavity with generally ill appearance, and the presence of maculopapular rash which starts at face to chest is a characteristic feature of measles. The risk of measles to the pregnant women, it causes significant morbidity and low mortality, but there is no evidence that measles can cause malformations of the developing embryo and fetus, whereas the risk of measles to the fetus or neonate, it includes there is a significant rise in the abortion rate, but it may also cause the fetal malformations. The mortality rate occurs in measles are 1 to 2 per thousand cases, which is often secondary to pneumonia or encephalitis. There is no evidence whatsoever that measles can cause malformations of the developing embryo and fetus. Measles can, however, trigger miscarriages, mostly spontaneous abortions, and premature delivery in pregnant women. Now coming to the mumps. Mumps, it usually results from infection with the paramyxovirus family, and it can lead to parotitis, meningoencephalitis, and otitis. Neurological complications such as deafness can also occur as a result of mumps infection. Mumps vaccines are contraindicated because it is a live attenuated vaccine carrying a risk of causing the mumps infection. It can cause early miscarriage or birth defects. The most common birth defect due to mumps is deafness. Now coming to the rubella, it is a German measles. Rubella is caused by Togavirus family. It crosses a placental barrier and causes a congenital rubella syndrome. It can cause 20% spontaneous abortion in the first trimester. The characteristic feature in rubella is the congenital rubella syndrome. It can result in defects such as the malformations of the eye, especially PDA, and malformations of the eyes and brain. And there is a deafness with spleen, liver, or bone marrow problems, some of which may disappear shortly after birth, with mental retardation, with small excites such as a microcephaly, and eye defects, cataracts, low birth weight, and epidermolysis. Measles, mumps, and rubella vaccine should not be given to a pregnant woman because of the potential adverse effects on the fetus, but should be vaccinated postpartum. Now coming to polio. It is an RNA enterovirus with 3 different strains that cause the disease. Exposure, it may result in asymptomatic infection as well as non-paralytic and paralytic disease. Asymptomatic patients can transmit the disease to susceptible persons. The disease continues to be a problem worldwide, but all recent domestic polio cases are being caused by the strains of the virus found in the oral polio vaccine. This situation has resulted in a change the recommendation for the use of inactivated polio vaccine instead of oral polio vaccine, or a combination of OPV and IPV for all routine vaccination. IPV is inactivated by formaldehyde, and its use has eliminated the vaccine-associated polio infection. Although no adverse effects have been documented with OPV or IPV in pregnant women or their fetuses, both the vaccines should be avoided during pregnancy on a theoretical basis. As per CDC recommendation, The IPV may be administered in accordance with the recommended schedule for the adults. The pregnant women is at increased risk for infection and requires immediate protection against polio. Now coming to the yellow fever. It is a viral hemorrhagic fever syndrome spread by the mosquitoes in parts of South America and Africa. The yellow fever vaccine is a live attenuated virus which is grown in the chick embryos. It is indicated for use in the laboratory workers, those who are involved with the virus, and in persons, those who are planning to travel to endemic areas. There is no specific evidence available to demonstrate the safety of yellow fever immunization during pregnancy. Since theoretical concerns of fetal infections exist, however, the vaccination is generally not recommended during pregnancy. When travel cannot be postponed and mosquito exposure is likely, yellow fever vaccination may be considered. Now coming to the inactivated vaccines. Inactivated viral vaccines are influenza, rabies, and hepatitis B, and inactivated bacterial vaccines are cholera, typhoid, and pneumococcus. Influenza, which has been characterized by fever, malaise, myalgia, and upper respiratory tract symptoms. The most severe complications are the result of pneumonia, which is secondary to influenza infection. The influenza vaccine is a killed virus preparation with an annually adjusted antigenic makeup. It should be administered annually between the October and December to high-risk patients. The vaccine should be administered to all pregnant women who will be in the second or third trimester of pregnancy, especially during the influenza season. Women in their second or third trimesters, they have higher morbidity from influenza infection. So that immunization must be avoided in most patients during the first trimester. This is to avoid a coincidental association with spontaneous abortion, which is common in the first trimester. Now coming to the rabies. Rabies is a viral infection which is transmitted most commonly by the saliva of the infected animals. It is characterized by non-specific prodromal symptoms which may progress to encephalitis. It has been marked by confusion and hallucinations. The dysregulation of the autonomic nervous system and involvement of the brainstem and cranial nerves lead to the classical appearance, that is, a foaming at the mouth in rabies. There are three forms of the inactivated rabies vaccines which are available in the market. All are considered to be equally safe and efficacious during pregnancy. The passive immunization is achieved through the administration of human rabies immunoglobulin, that is HRIG, so that the indications for pre-exposure immunization depends on the likelihood of exposure. It may be considered in animal workers and travelers to exotic areas who anticipate animal exposure. With any animal bites or wild animals, the animal should be euthanized and the brain must be tested for infection. But bites from the normally acting dogs, cats, warrants a 10-day observation period with prophylaxis and euthanization of the animal is deferred. In patients, those who have not been immunized previously, 20 international units per kg of HRIG, that is human rabies immunoglobulin, is given around the wound site for iris bites or if testing is positive. Patients with previous vaccination for rabies do not need the HRIG, that is immunoglobulin, but they do require pre-vaccination on a modified schedule. There have been no identified association between the rabies vaccination and fetal abnormalities. Now coming to hepatitis B. Hepatitis B is mainly transmitted through contact with the infected blood, through sexual activity, as well as the sharing of intravenous needles. The risk of developing chronic illness associated with complications such as the cirrhosis, hepatocellular carcinoma, and a chronic carrier state has been a key factor in the recommendation for universal vaccination of all children. The risk factors for a pregnant woman includes having multiple sexual partners, using or abusing intravenous drugs, having occupational exposure, and being a household contact of acutely infected persons or persons with chronic carrier state. The hepatitis B vaccine contains a surface antigen which has been produced by the recombinant DNA technology. It is administered in the fetus at 3 doses, one at the birth, second dose at 1 month, and third dose at 6 months of age. It has minimal to no side effects. because it contains a non-infectious hepatitis B surface antigen particles and it causes no risk to the fetus. Neither pregnancy nor lactation is a contraindication to hepatitis B vaccination. Now coming to typhoid. Most cases of typhoid fever in developed countries occur in travelers who recently have returned from high-risk areas such as South America, India, and Western Africa. The transmission of Salmonella typhi is significantly increased with the travel during the local epidemics, so as well as the ingestion of food from street vendors. The primary prevention of typhoid it consists of hand washing, drinking only safe water, peeling all fruits and vegetables, and eating well-cooked foods. There are two types of typhoid vaccination in use today. One is the live attenuated oral vaccine, and second one is the parental polysaccharide vaccine. Both the forms require that immunization must be completed at least 2 weeks before exposure. Typhoid vaccine is contraindicated in infants, immunocompromised persons, and those with abnormal GA function, as well as pregnant women. Neither form of typhoid vaccine is officially recommended during pregnancy. Now coming to cholera. Cholera is an acute diarrheal disease which is endemic to Africa, Asia, and Latin America. It is caused by a toxin from Vibrio cholera bacteria, which is transmitted by the fecal-oral route from contaminated water resources. There are two oral vaccines available for cholera. One is a killed vaccine, which is a whole cell recombinant vaccine, and another one is a live attenuated strip. Both are more effective, better tolerated, and longer lasting than the parental vaccine. These vaccines may be considered for use in populations at immediate risk of cholera epidemic or for travelers to areas of high endemicity. There is no specific information exists on the safety of parental cholera vaccination during pregnancy because cholera during pregnancy is a serious illness, so that exposure should be minimized during pregnancy whenever possible. Now coming to pneumococcal vaccines. Streptococcus pneumonia is a gram-positive diplococci that is the major cause for pneumonia, meningitis, and bacteremia. The risk factors for pneumococcal infection in pregnant women, it includes diabetes, cardiovascular disease, immunodeficiency, as well as asthma. The current vaccine for pneumococcus, it includes purified capsule polysaccharide. Women who are at high risk should be given this vaccination before pregnancy, but not during the pregnancy time. The safety of the pneumococcal vaccine during pregnancy has not been evaluated, although no adverse outcomes have been reported among the newborns whose mothers were inadvertently vaccinated. Now coming to the immunoglobulins vaccines, it includes hepatitis B, rabies, tetanus, and varicella. Varicella vaccination is a live attenuated virus, so that it is contraindicated during pregnancy. The adverse effects of varicella has been characterized by limb atrophy and scarring of the skin of the extremity, which is most popularly known as congenital varicella syndrome. This picture shows an infant whose mother had varicella during the 13th week of pregnancy, which has been presented with bilateral microophthalmos and an atrophic left leg. Other manifestations of varicella, it includes central nervous system abnormality as well as abnormality in the eyes. There is increased mortality rate in infants, those who are infected with varicella. The varicella zoster virus causes chickenpox, and rarely it causes very serious complications such as encephalitis and severe pneumonia. Up to 15% of infected persons have herpes zoster later in life. And the women who are vaccinated should avoid becoming pregnant for 1 month following each injection. The presence of pregnant household members does not constitute a contraindication for vaccination of others within the house. Now coming to the indications of varicella immunoglobulin. If a susceptible pregnant woman is exposed to varicella, however, the administration of varicella zoster immunoglobulin should be strongly considered. It also been indicated for newborns of mothers who develop varicella within 4 days prior to delivery or 2 days following delivery. Approximately 90 to 93% of adults are immune. Now, it is not indicated for the prevention of congenital varicella syndrome. Now coming to tetanus and diphtheria. Diphtheria is an infection of the nasal, pharyngeal, laryngeal, or other mucous membranes that can cause neuritis, myocarditis, thrombocytopenia, and ascending paralysis. Tetanus infection, it can cause production of a neurotoxin which can lead to tetanic muscle contractions. Tetanus toxoid is routinely recommended for susceptible pregnant women. While no evidence exists to prove that tetanus and diphtheria toxoids are teratogenic, waiting until the second trimester of pregnancy to administer toxoids is a reasonable precaution which minimizing any concern about the theoretical possibility of such reactions. Who needs a tetanus and diphtheria vaccine? Previously vaccinated pregnant women who have not received a TB vaccination within past 10 years should receive a booster dose. Pregnant women who are not immunized or only partially immunized should complete the primary series. Now coming to the other vaccination, it includes hepatitis A vaccine. Hepatitis A is mainly acquired via the fecal-oral route by person-to-person contact or by ingestion of contaminated food or water. Safety during pregnancy has not been determined for hepatitis A vaccine because hepatitis A vaccine is produced with an inactivated virus. The risk to the developing fetus is expected to be low. The administration of immunoglobulin is strongly recommended, which is considered safe during pregnancy, and it is more than 85% effective in preventing acute hepatitis. Now coming to meningococcal vaccine. In the USA, the meningococcal disease is the leading cause of bacterial meningitis in children aged between 2 to 18 years of age. The meningococcal vaccine, it contains a purified polysaccharide of 4 serogroups of Neisseria meningitidis. The routine vaccination of meningococcal vaccine is recommended only for high-risk groups, including military recruits, patients with terminal component deficiencies, and persons with anatomical or functional asthenia and high school or college students. Vaccination also may benefit the travelers who are residing in areas in which Neisseria meningitidis is endemic or epidemic, such as Africa. Studies have shown that the meningococcal vaccine is safe and efficacious when given to pregnant women. Vaccinations typically not administered on a routine basis by family physicians and other vaccines of interest during pregnancy. It includes anthrax, smallpox, rabies, yellow fever, BCG vaccine, typhoid vaccine, and cholera vaccine. Now coming to BCG vaccine. Mycobacterium tuberculosis causes more than 8 million new cases of tuberculosis annually, the majority of them in developing countries. BCG vaccine is a live vaccine which has been derived from a strain of Mycobacterium purpus. It is likely that the BCG vaccine has been given to thousands of pregnant women in other countries, while no harmful fetal side effects have been identified till date. Use of the BCG vaccine is not recommended during pregnancy, so that the preconception immunization of pregnant women to prevent disease in the offspring is preferred more than the vaccination of a pregnant woman. The benefits of immunization to a pregnant woman and a neonate usually outweigh the theoretical risk of adverse effects. The theoretical risk of the vaccination of pregnant women with killed virus vaccines have not been identified till date. The vaccination of women during the postpartum period, especially for rubella and varicella, should be encouraged. Women who are susceptible to rubella should be vaccinated with measles, mumps, rubella on postpartum during her discharge from the hospital. Generally, the live virus vaccines are contraindicated for pregnant women because of the theoretical risk of transmission of the vaccine virus to the fetus. Whether live virus vaccine or inactivated vaccines are used, vaccination of pregnant women should be considered on the basis of the risk of the vaccination with the benefits of protection in a particular circumstances. Now coming to the immunizations during pregnancy as per recommendations of Advisory Committee on Immunization Practices. The immunizations which are considered to be safe during pregnancy are tetanus and diphtheria toxoid TB, Another one is hepatitis B, influenza vaccine, meningococcal vaccine, and another one is rabies vaccine. And certain immunizations are contraindicated during pregnancy because the safety has not been established. That is BCG vaccine, measles, mumps, rubella, and varicella vaccine, because these vaccines are live attenuated vaccines, and certain vaccines are recommended in special circumstances. It includes anthrax vaccine, hepatitis A, Japanese encephalitis, pneumococcal vaccine, polio, that is inactivated poliovirus vaccine IPV, typhoid vaccine, that is in the parenteral route, and typhoid 21A, and vaccinia and yellow fever vaccine. Vaccinia and yellow fever vaccine are the live virus vaccines. Now we are going to discuss about the COVID vaccinations and certain guidelines which are followed in India for COVID vaccination in pregnant mothers. All pregnant women should be vaccinated for COVID. The pregnant women should be vaccinated in all trimesters, even in the first trimester. High-risk mothers like pre-eclamptic mothers, gestational hypertensive mothers, gestational diabetes mellitus, anemia complicating pregnancy should be given Covaxin, and previous cesarean section and RH negative patients may not be taken as high risk. Epileptic mothers and RTCs mothers, they should be vaccinated in medical colleges after expert opinion. Patients who are on heparin, aspirin, and those who are conceived after IVF program and those who are with DVT need to be vaccinated in tertiary care hospitals. If needed, we can get expert opinion. For low-risk mothers, Covishield should be given. TB and COVID vaccines can be given in the same day but at different sites, one in the right arm and another one is the left arm. But in case if want to be on more safer side, then also 2 weeks interval. Anti-D and COVID vaccine can be given on the same day but at different sites. COVID vaccine can be combined with a blood transfusion as well as iron sucrose. COVID vaccine and sterilization can go hand in hand. Interval between the two doses of vaccine is the same as for non-pregnant adults are considered. Vaccines to be given for 18 years of age onwards only. If mother is COVID positive, leave 3 months gap before the vaccination. Counsel the mothers and vaccinate the pregnant mothers as soon as possible. Vaccination status of the mother to be written preferably by a rubber stamp in the RCH ID card, mentioning the date of first dose and what vaccine is given and the date of second dose. If a pregnant mother is not willing for vaccine, even after repeated counseling, it is to be highlighted in the RCH card. The vaccinated mother should be followed up for 20 days by the staff for the side effects. All antenatal mothers who are referred to tertiary care for vaccination, they should be accompanied by the village health nurse. Women on long-term contraceptive pills should get an expert opinion and then vaccination should be done. As such, no contraindication for COVID vaccination in pregnancy. We should aim to cover as soon as possible all antenatal mothers by COVID vaccination. Thank you.